Eye motility recording, a guide to treatment in nystagmus patients. Hello friends, do you know that nystagmus comes from the Greek word nystagmos, meaning to nod? A nystagmus is an involuntary rhythmic to and fro movement of eyes with a pathological slow phase moving the fovea away from the fixation and a corrective refixation phase which can be fast or slow. Characteristic pattern of waveforms in pathological slow phase differentiate between acquired and infantile nystagmus and between the types of infantile nystagmus. These waveforms can be accurately recorded with the help of highly precise and versatile video-based eye tracker. Besides, null zone can be tracked in case of abnormal head posture, and a shift in null zone after nystagmus surgery can also be appreciated. A very important parameter of quality of foveal fixation is nystagmus optimal fixation function or NOF values. It takes the logarithmic value of fraction of points within the optimal 4-second segment that meet the simultaneous position of less than 1 degree and velocity of less than 6 degree per second criteria. NOF value nearing 1 or more is compatible with good visual acuity. To record the eye motility, the patient is made to place chin on a rest and a target is given to observe the nystagmus characteristic in primary and various cardinal directions. With this background, I would like to take you through few cases of different types of nystagmus and its characteristics findings in eye motility recording. We will also learn few parameters to look for in EMR which will help us to modulate our treatment plan in these patients. This is a 25-year-old male with a jerky left beating nystagmus in primary gaze. Eye motility recording shows classical accelerating slow phase confirming the diagnosis of infantile nystagmus syndrome. This patient has reasonably good visual acuity as the NOF value is good, but was suffering from occasional oscillopsia. Hence, to improve vision further and to reduce the oscillopsia, contact lens was prescribed, which acts by alteration of proprioceptive feedback loop principle. And we can see clearly that NOF values improved further in subsequent recordings. This child presented to our clinic with the right beating jerky nystagmus. His nystagmus showed fast phase in the direction of fixing eye and along with the latent component on occlusion of either eye. Hence, it is a case of fusion maldevelopment nystagmus syndrome, which is confirmed by decelerating slow phase in eye motility recording. He underwent Kastenbaum procedures for associated abnormal head posture. Patient is yet to come back for post-operative eye motility recording. However, one would expect reduction of amplitude and velocity of nystagmus and improvement in NOF value similar to the previous case. This is an eye motility recording printout of a 23-year-old male with an abnormal head posture of left head turn 30 degree and expected null zone in dextroversion, which is correlating with EMR recording as we are seeing that amplitude and velocity are minimum at position 1. Hence, we operated him with a Kastenbaum-Anderson procedure to correct his AHP and we would expect the null zone to be shifted to primary zone. Instead, we saw that nystagmus dampening effect occurring on range of gazes. Interestingly, literature also says that post-nystagmus surgery, amplitude and velocity reduces over the range of gazes instead of correcting it just for a primary gaze. His post-operative video recording shows reduction of nystagmus even clinically over large degree of gazes. This case of 12-year-old male, which is a very interesting case of alternating AHP and nystagmus since birth, where we suspected it to be periodic alternating nystagmus. And we confirmed it with the help of eye motility recording, where we can see right beating nystagmus changing to left beating after 135 seconds. It is very important to pause and observe all the nystagmus patient for minimum of 3 to 5 minutes to not to miss periodic alternating nystagmus. Supramaximal recession of all 4 recti muscle is the surgery of choice in such cases. Lastly, this 59-year-old gentleman is having acquired nystagmus, which showed characteristic pendular elevation and intorsion of one eye with depression and extrusion of other eye. Yes, it is a case of seesaw nystagmus due to pontine infarct affecting MLF carrying vertical semicircular canal inputs. To confirm, eye motility recording was done, which showed disconjugate nystagmus prominent for vertical and misalignment of eyes changing direction. He was started on tablet baclofen, which acts on proprioceptive feedback. Serial recording showed improvement of foveal fraction and NOF values. Patient also subjectively feels much improvement in his oscillopsia. So friends, what did we learn today? Let's recapitulate. We can divide our learning into two parts. In part 1, we learned classical EMR pattern of various types of nystagmus, which are as follows. Accelerating slow phase is characteristic of infantile nystagmus syndrome, whereas decelerating slow phase waves are seen in fusion maldevelopment nystagmus syndrome. Linear slow phase can be seen in FMNS or acquired type. 3 to 5 minute observation of nystagmus characteristic is must to rule out or rule in periodic alternating nystagmus. And our second learning is about various parameters in eye motility recording which help us monitor the effect of treatment are reduction of amplitude and velocity, widening of null zone, and improvement of foveal fraction and NOF values. I hope this video would improve our understanding of various types of nystagmus with the help of eye motility recording. And by observing above mentioned parameters, it also tells us whether our treatment is effective or would require any other modification. Thank you.